I'm going to present today venous thromboembolic disease, pathophysiology, epidemiology, and natural history. A non-thrombogenic endothelial surface is maintained through a number of mechanisms, including endothelial production of thrombomodulin and subsequent activation of protein C, endothelial expression of heparin sulfate and dermatan sulfate, which accelerate antithrombin and heparin cofactor activity, constitutive expression of tissue factor pathway inhibitor, local production of tissue plasminogen activator, and urokinase type plasminogen activator. Elaboration of nitric oxide, prostacyclin, and interleukin 10 by endothelin inhibits the adhesion and activation of leukocytes and produce vasodilation. But in contrast, during stages of endothelial disturbances, there will be release of platelet activating factor and endothelin 1, which promotes vasoconstriction, which will be there will be production of one Willebrand factor, tissue factor, plasminogen activator inhibitor 1, and factor 5. Endothelial cells are activated, then it will result in the increased expression of cell adhesion molecules P-selectin or E-selectin. This is a picture showing the recruitment of various various cells, lymphocytes, monocytes, neutrophils, and platelets. Overall, the coagulation system, the outcome of the coagulation depends on three pathways. One is the coagulation pathway, which has a extrinsic pathway and intrinsic pathway. The other one is a protein C pathway, which will be including protein S also. They inhibit the factors 5 and 8. And at the end, when fibrin is formed, there will be a fibrinolytic system. The overall coagulation happens in one's body will be depending on the three pathways. Thrombin factor 2 is central to coagulation through its action of cleavage of fibrin, which will result in release of fibrinopeptide A and fibrinopeptide B. Then fibrin monomer polymerization and cross-linking occurs, which stabilize the thrombus and the initial platelet plug. Thrombin also activates factor 13 to 13A, which catalyzes the cross-linking of fibrin. Factor 13A activates platelets also, as well as factors 5 and factor 8. Coming to the action of platelets activation and formation is a primary thrombotic event happens in coagulation episode. The subendothelial collagen, it may bind directly to the glycoprotein 6 and one Willebrand factor, leading to platelet capture and activation. Platelet interactions and activation are mediated by one Willebrand factor. The receptor for one Willebrand factor is glycoprotein 1B, and platelets get adhered to the fibrin by glycoprotein 2B and 3A. The activation of platelets leads to release of prothrombotic contents of platelet granules, which contains receptors for coagulation factors 5 and 8A. The platelet activation also leads to release of thromboxane A2, which may cause platelet aggregation and vasoconstriction. Platelets also release microparticles, which will be rich in tissue factor and other procoagulants. Circulating tissue factor is more important in venous thrombosis than in arterial thrombosis. Then the inhibitors of fibrinolytic pathway, plasminogen inhibitors and thrombosis. Plasminogen activator inhibitor 1 is the primary inhibitor of plasminogen activators. It is secreted in active form from liver and endothelial cells, and this is bound to vitronectin. The plasminogen activator inhibitor 1 is stored in alpha granules of platelets. Then coming to the in the coagulation pathway, there may be some amount of inflammation also. Inflammation and thrombosis, the relationship was first suggested in 1970. Inflammation increases coagulant factors like tissue factor, membrane phospholipids, fibrinogen, and it will increase the reactivity of platelets, which it will decrease the thrombomodulin and inhibit fibrinolysis. The markers of inflammation were once thought to be soluble, but now it is found that it is actually carried by a small phospholipid vesicles less than 1 micrometer, which are called as microparticles. Different cells will shed off microparticles include platelets, leukocytes, endothelial cells, which is a calcium-dependent pathway, and that itself will initiate and amplify the thrombosis. Fusion of the microparticles with platelets will cause release of tissue factor, and that also initiate thrombosis. And microparticles from platelets may express plasminogen activator 1, activator inhibitor 1, and these microparticles, in addition to they causes thrombosis, they will also inhibit fibrinolysis. And microparticles will increase the interaction between P-selectin and its receptor, P-selectin glycoprotein ligand 1. In this manner, platelet microparticles are not only prothrombotic, they are inhibiting fibrinolysis also. Then one molecule which is upregulated in microparticles, which is shown in microparticles, is galectin-3 binding protein. It's a member of lectin family, and galectin-3 could be a potential marker in patients with acute deep vein thrombosis. Both galectin-3 binding protein and galectin were found to be elevated in all the tissues and blood elements pertinent to the thrombus formation. Then coming to the epidemiology of uh, venous thromboembolism, there will be 9 lakh cases annually. And venous thromboembolism is associated with a number of risk factors. The main complications of venous thromboembolism include recurrent thrombosis and mortality, pulmonary embolism, and post-thrombotic morbidity. Then coming to the each risk factor, first one is age. It's a acute prothrombotic condition. The risk for venous thrombosis increase with age, and it is noticed that anatomy changes in the soleal veins, and more stasis will be occurring in the venous valve pockets with increased age. Second one is immobilization. There will be stasis in the soleal veins and behind the valve cusp, which is worsened by inactivity of the calf muscle pump. It is noticed that increase in risk is occur during the first 3 days of confinement, and it will be rapidly rising to very high levels after 2 weeks. Traveling long time can cause will increase the risk for venous thromboembolism. It's called economic class syndrome. It occurs usually with the presence of other risk factors also. Then history of previous venous thromboembolism. It is not that 23 to 26% have a previous history of thrombosis. The fibrous remnants of previous thrombi can act as a nidus for the future venous thromboembolism, and there may be primary hypercoagulability associated with recurrent thrombosis. And malignancy, 20% of all first-time venous thromboembolic events are associated with malignancy. The highest rates are found in pancreatic malignancy, followed by kidney, ovary, lung, and stomach cancers. The venous thromboembolism occurs in malignancy may be multifactorial, which includes a venous compression secondary to tumor growth, cancer associated with thrombocytosis, immobility, indwelling central lines, chemotherapy or radiation therapy, and there may be a systemic prothrombotic response associated with the malignancy. The systemic thrombotic response in malignancy include a constitutive expression of tissue factor, which will increase the thrombus formation through extrinsic pathway, and cancer coagulant, which will directly activate factor 10 independent of the presence of factor 7A. The platelet adhesion molecules glycoprotein 1b and glycoprotein 2b 3a on tumor cells will cause increased platelet activation and aggregation. Then thromboembolism, sir. First is age. It's an acute prothrombotic state, sir. The risk for venous thromboembolism increase with age. There may be anatomic changes in the soleal veins and more stasis in the venous valve pockets. And next one is immobilization. There will be stasis in the soleal veins and behind the valve crest, which is worsened by inactivity of the calf muscle pump. Uh, During bed rest, there will be increase in risk during the first 3 days of confinement, and it will rapidly rise to very high levels after 2 weeks. Then travel increases the risk for venous thromboembolism. Usually, there may be presence of other risk factors also. This is called as economic class syndrome. And then coming to the history of venous thromboembolism itself. 23 to 26% of patients have a previous history of thrombosis. There will be the fibrous remnants of the previous thrombi can act as a nidus for future thrombosis. And there may be primary hypercoagulability, which may be causing recurrent venous thromboembolism. Then malignancy, 20% of all first-time venous thromboembolic events are associated with malignancy. The highest rates were associated with pancreatic malignancy, followed by kidney, ovary, lung, and stomach cancer. It may be multifactorial, maybe due to venous compression secondary to tumor growth, cancer-associated thrombocytosis, immobility, indwelling central lines, chemotherapy or radiation therapy. Systemic thrombotic response. The systemic prothrombotic response in malignancy is due to constitutive expression of tissue factor, and there is cancer procoagulant, which it's the direct activator of factor 10 independent of the presence of factor 7A. The platelet adhesion molecules, glycoprotein 1B and glycoprotein 2B 3A may be found on tumor cells, which leads to platelet activation and aggregation. Then the growth factors like vascular endothelial growth factors will be produced, and cytokines like tumor necrosis factor and interleukin 1, which will stimulate the production of plasminogen activator inhibitor. And there will be elevated fibrinogen and increased platelets. Antithrombins, protein C and protein S also may be reduced. The thrombogenic mechanism associated with the chemotherapy will include endothelial toxicity, induction of a hypercoagulable state, reduced fibrinolytic activity, tumor cell lysis, and use of central venous catheters. And then coming to surgery, surgery constitutes a spectrum of risk, like the patient age, coexistent thrombotic risk factors, coexistent thrombotic risk factors, type of procedure, extent of surgical trauma, length of procedure, duration of post-operative immobilization. How, sir? Approximately 19% in patients undergoing general surgical operation, 24% in elective neurosurgical procedures, 48% in surgery for hip fracture, 51% in hip arthroplasty, and the highest is for knee arthroplasty, which is 61%. The thrombogenic mechanism associated with surgery include the perioperative immobilization, transient changes in coagulation and fibrinolysis, and potential for gross venous injury. Surgery is accompanied by a lower level hypercoagulable state, which is mediated by the release of tissue factor, and there will be increased levels of plasminogen activator 1, inhibitor 1, and it is observed during the first post-operative day, that is called as post-operative fibrinolytic shutdown. The strongest predictors of post-operative venous thromboembolism include myocardial infarction, blood transfusion more than 4 units, and urinary tract infection. Then trauma. In trauma, certain subgroups are at particularly high risk, including increased age, blood transfusion, surgery, fracture of femur or tibia, spinal cord injury, pelvic fractures, hospital stay longer than 7 days, increased ISS score, major venous injury, presence of femoral venous lines, and increased duration of immobilization. Thrombogenic mechanisms associated with trauma include immobilization by skeletal fixation, paralysis, and critical illness that will cause venous stasis, and mechanical injury that may be direct venous trauma or central venous cannulation, and there will be an associated hypercoagulable state also. after depletion of coagulation inhibitors and components of fibrinolytic system. Then pregnancy, it is noted that 10% of all maternal deaths are caused by venous thromboembolism. The risk of thrombosis appears to be 2 to 3 times greater during the period, with the highest incidence found after cesarean section. When venous thromboembolism is objectively documented, it is noted that the occurrence of thrombosis is same through all the trimesters. And 30 to 50% of the patients having venous thromboembolism in pregnancy would have an inherited thrombophilia. The risk of peripheral DVT increases with maternal age, suppression of lactation, hypertension, and assisted delivery. The thrombogenic mechanisms associated with the pregnancy include impaired venous outflow due to uterine compression. Pregnancy is associated with a hypercoagulable state with increase in different factors, including fibrinogen, von Willebrand factors 2, 7, 8, and 10. There may be an acquired functional resistance to activated protein C. Protein S levels also decreased by 50 to 60% during pregnancy. And fibrinolytic system is also altered. Levels of tissue plasminogen activator are decreased, and plasminogen activator inhibitor 1 and 2 are increased. Then oral contraceptives and hormonal therapy. 1/4 of idiopathic thromboembolic events occurring in the women of childbearing age is due to oral contraceptives. And the increased risk of thromboembolism appears to diminish once the oral contraceptives are discontinued, and it is independent of the duration of use. The odd ratio of thrombosis is from 3.8 to 11 for 11. Risk is correspondingly higher when oral contraceptive use is combined with other factors such as surgery and inherited inhibitor deficiency. The estrogen compounds increase the risk of venous thromboembolism when used for lactation suppression in carcinoma of prostate and as postmenopausal replacement therapy. There is 2 to 4-fold higher risk of venous thromboembolism among women taking hormone replacement therapy. The increased risk is during the first year of hormone replacement therapy. The thrombogenic mechanisms associated with these hormones include decrease in plasminogen activator inhibitor 1 and increase in blood viscosity fibrinogen, plasma levels of 7 and 10, and platelet adhesion and aggregation. There will be elevated levels of factor 7A, decrease in antithrombin and proteinase inhibitor activity. Then coming to blood group. It is noticed that there is a high prevalence in blood group type A and low prevalence in blood group O group. It is greater in case of young women who were taking oral contraceptives or were pregnant. Then geography and ethnicity. It is noted that it depends on the mutation in specific genes. Then inflammatory bowel disease. It has been reported that in Crohn's disease and ulcerative colitis there is a high incidence. And it occurs mostly in young patients and with patients who are having active disease, and it occurs in unusual size like cerebral veins. And the greater the extent of the colonic disease, there will be a greater risk of venous thromboembolism. The active inflammation is associated with activation of coagulation, possibly it's due to endotoxin induced monocyte activation. In SLE, lupus anticoagulant and anticardiolipin antibodies may be seen, and the lupus anticoagulant is associated with a 6-fold higher risk for venous thromboembolism, and anticardiolipin antibodies are associated with 2-fold increase of venous thromboembolism. The incidence of arterial venous thromboembolism is 25% in patients with lupus anticoagulant and 28% in patients with anticardiolipin antibodies. Then varicose veins, iliac vein compression, and popliteal vein enlargement. Varicose veins are included as a risk factor of acute DVT. Most studies have been conducted on patients who are already having a thrombotic risk. So the importance of varicose veins in other healthy outpatients with DVT has been questioned by some researchers, and it's controversial. Then iliac vein compression. The most important one is May and Turner syndrome, in which it can be DVT of left iliofemoral DVT. Then popliteal vein entrapment. It can also can be associated with DVT. Other risk factors include inherited thrombophilias, thoracic outlet syndrome, central venous catheters, and inferior vena cava abnormalities. Traditional risk factors for venous thromboembolism have included obesity and cardiac disease, but both are controversial. Among postmenopausal women, a body mass index of greater than 25 to 30 kilogram per meter square has been associated with a significantly increased risk of venous thromboembolism. This is to assess the risk factors for Kaplan score. This is to assess the risk factors for venous thromboembolism. Then coming to the natural history of venous thromboembolism, it occurs, it's like relative balance between organization, thrombolysis, propagation, and rethrombosis. The, uh, the most important events after thrombosis are recanalization and recurrent thrombosis. Coming to the thrombus resolution and vein wall remodeling. In humans, the natural fibrinolytic mechanism will act once DVT has happened, and it will lead to breakdown the thrombus over time. The first leukocyte subtype to get recruited in the thrombotic site is polymorphonuclear neutrophil. The neutrophil can cause vein wall injury, and it can cause increased thrombus formation, and then it will cause early thrombus resolution. Then the monocyte is recruited after once neutrophils have been recruited. And then there may be increased production of growth factors like hypoxia inducible factor 1 alpha, vascular endothelial growth factor. This is a figure showing the yearly changes in less than 8-day changes in thrombus, where you can see the maximum the leukocytes recruited are the neutrophils, and after 9 days the monocytes will be recruited. There will be pro-inflammatory factors will be released in the thrombus, including interleukin 1 beta and TNF alpha. And there will be a elastinolysis and collagenlysis, which will be persisting through 14 days, and it will be accompanied by elevated matrix metalloproteinase 2 and 9. Then after that, there will be fibrotic growth factor, transforming growth factor beta will be released, and it is associated with normal thrombolysis. And after that, the fibrosis of the vein wall can occur due to the production of collagen 1 and 3. This is a figure showing the early acute DVT and chronic DVT. In acute DVT, you can see different cells are recruited into the thrombus, including neutrophils, and different molecules are represented in the picture. And chronic DVT, it is mainly due to the activity of the fibroblasts and the smooth muscle cells. Recanalization, it begins early after an acute DVT, and the greatest reduction is seen within 3 months of the event. And complete resolution has been reported in 56% of the patients monitored for 9 months. The recanalization may continue for months to years after the acute event. The recurrent venous thrombosis, nearly 30% of patients will develop a recurrence within a 10-year time span, and the recurrences are more likely with the same event type as the incident event. Independent predictors for recurrent DVT include increasing age, obesity, malignant neoplasm, and extremity paralysis. Mortality, there will be some 1% incidence of pulmonary embolism and 0.36% incidence of death from pulmonary embolism in all hospitalized patients per year. Thank you, sir.